Hello and welcome to our webinar. Today's topic is screening tools for mental health and other disorders that may impact a student's ability to be successful in school or in life. If there are other topics that you would like to see us cover in one of our webinars, please contact me at dale.gasparovic@prevention.org. Also, you can follow us on Twitter at SACenterPF, or you can email me. Again, my email is dale.gasparovic@prevention.org to join our Student Assistance Center group site. Our presenter today is Don Mitkus, and I'm going to turn it over to you now, Don. Let me pass this off to you here. If I can figure it out. There we go. It's coming your way.
Okay. Thanks, Dale. This is Don Mitkus. As Dale had mentioned, I'm a consultant with Prevention First for the Student Assistance Center. Been a therapist that's been working with school-age kids for more years than I care to think of. And today, what we're going to cover are some screening tools for mental health and behavioral health issues in schools. There's a few things that we're going to cover today. This is a real broad brush on the different screening tools that are out there for different issues. And we'll talk about the broad versus specific. And but what I wanted to start out with is why screen? Why do a screening? And then we'll talk about what is a screening. But why screening? There's a huge unmet. Certainly, behavioral health issues are one of the most under-identified issues with our kids. It's easy to see when they're failing in math or in reading. We have these tests and measures and evaluations and state tests and all these things that tell us how well someone is doing academically, but we don't necessarily have things in place that tell us how our kids are doing on the social emotional spectrum. And the need is enormous. 1 out of 5 kids have a diagnosable behavioral health condition, and the sad part of it is that 80% of school-age kids 6 to 17 years old, that need mental health services do not receive them. And those that do receive them, the challenge is, are they getting connected with the appropriate type of care and service to address their particular needs? And as we see in the classroom and in our schools, when someone has a mental disorder, one of our children, and it goes untreated, the likely expectation is that disorder is going to get worse. When you don't treat something, we don't treat a pathology, it doesn't just coast. It will continue to worsen as they develop more and more dysfunctional coping skills to deal with the symptoms they're experiencing. In an untreated mental disorder, again, if gone unchecked, can lead to the development of other disorders. Typically, we see disorders develop when people are attempting to cope with the primary mental disorder they're dealing with. So it's not unusual for those that are suffering from anxiety to start to self-medicate with things like alcohol or marijuana. It's not unusual for someone who's suffering from depression to start experimenting with other dysfunctional coping skills such as non-suicidal self-injury or eating disorder behaviors in an attempt to control the symptoms that they're experiencing, which all leads to essentially a functional impairment. These untreated mental disorders impair these children and emerging adults, impairs their ability to function in their life roles. So things such as difficulty in school, difficulty with attendance, difficulty with behavior. These are all very real consequences of a mental disorder that goes untreated. And one thing I do want to point out is it's not necessarily on one of our slides, but the difference between what is a screening and what is its purpose. The thing to keep in mind is screening is not to say this is the problem someone has. It's not to diagnose. Screenings are not sensitive enough or sophisticated enough to diagnose a condition. What a screening is for is to determine if someone needs further evaluation. That is it. Even the very specific screening tools that we'll talk about, their role is to say, yep, this looks like this person might have an issue in this domain, and needs to be seen by someone who is qualified to actually render a diagnosis or to recommend some form of treatment. Screening tools are not meant to be an end result. It's not meant to be screen, say this is the issue, and go no further. What they're meant to do is to look at what individuals' needs are and point them in the direction of the services that would be appropriate to them to address that issue. So it's in hopefully with screening tools is that you're going to be able to screen for these issues earlier in their disease process, and hopefully catch them at a point where it will be easier to remediate, more responsive to treatment. The longer that a mental disorder or behavioral health disorder goes on, the more complicated and treatment resistant it becomes. So if we can find these things out when they're in elementary or middle school versus when they come out because they're unable to function in high school, you give that kid a much better shot at having a successful academic career. So this slide here just kind of drives home the point that that the need is there, but it's not being addressed. Those kids are not receiving care. One thing I had to remind myself when I was working in a school was that the kids I saw, as I ran the student assistance program at a large high school in Metro Chicago area, was that I was only working with about 20% of the kids, which is still a significant amount. What that means is that 8 out of 10 kids are just fine. Will have normal developmental issues and normal developmental challenges for an adolescent, but in general, these kids are just fine. It's that 20% that do have some form of diagnosable behavioral health disorder that are of concern. Out of those kids, out of that 20%, only about 20% of those are actually receiving appropriate care and treatment for their disorder. 80% are not, which is remarkable. There are a lot of kids that go, it either goes unrecognized or it goes, it's not considered significant enough by their support system to actually get them help. So it is incumbent on us as those that as identifiers, and that's really what we are. We are identifiers to say, if there's something going on with this kid, it's likely in this domain, and be connected enough with our local resources to get them connected with someone that can provide an accurate diagnosis and initiate appropriate care and treatment. So while we talked about untreated mental health disorders causing functional impairments, this chart talks about graduation and dropout rates for youth with emotional disturbances versus and youth with any disability. So these are kids that are on an IEP, that those with an emotional disturbance are far more likely to drop out or far more likely not to graduate than those with other forms of disability. So these are all kids that have special needs and are getting special supports in the school, but those with an emotional disturbance are far more functionally impaired than other special ed kids. So, which just points out that the need for screening to identify what support services they might need is even more crucial to the success of these kids. So why screen in schools? Why not leave it up to public health or the parents? Frankly, it's where the children are. They're all there. It's where you get the most bang for your buck. When you're doing a general screening, you're not only looking to identify kids, but you're also looking to identify, as an organization, as a school, as a school building or a school district, where your resources need to be focused. So if you're doing a screening at school and there's a high incidence of depression, that's a good indicator that you need to beef up your universal prevention efforts for that particular issue. Or if there are a lot of kids that are involved with substance use, where are your primary prevention efforts and what do you need to focus on? Screenings not only provide a clue as to which kids are in need or could use additional assistance or referral, but also points out where the needs of your school community are. It gives you a large data set to work with, which is vital, especially if you're if you know as a social worker or counselor or school psych or a student assistance program team member or coordinator, that your school is really struggling with a particular issue. Your school culture, your school climate is conducive to substance use, for instance. Getting data to support that assertion, what you know to be true from your experience working with kids and it being in tune with where the hearts and minds of your students are at. But the data is necessary and essential to back it up to make an argument to your administration that you need additional resources, or you need resources to engage in partnerships with those that can help you initiate programs that can impact that number. Also, if there's not only screening, but if there are partnerships that are developed to address those needs once they're identified, a school health center, support groups, outside agencies that the school contracts with to provide counseling in the schools, a group, an individual, or assessment. Students are more likely to follow through with those services if they're at the school, again, because they are already there. So even if it's an after school or before school thing, they are more likely to follow through and engage in those services from a matter of convenience. The resources, the emotional, financial, constitutional resources of families that have a family member or child that is struggling with an emotional disturbance are often very taxed. Or if they have limited resources as far as insurance coverage, Medicaid, which is often insufficient in allowing options for that family to seek treatment. If there's something available at school, the family's more likely to engage in it rather than having to travel. If you're outside the Chicago metro area, you could be traveling 30, 40, 50, 60 miles to get to a community mental health center. If those services are available at school, not only the kid but the family is more likely to follow through with it as well. And as mentioned before, mental health problems interfere with learning and achievement, not just for that individual, but sometimes the way the symptoms of these disorders manifest, it can be disruptive to the learning environment of other students. If they're anxious and they're having to pop up every 5 minutes because they can't sit still or sit down, can't tolerate that immobility for a 40-minute class period, that's disrupting the learning environment. If they're suffering from an agitated depression, where rather than for adolescents, an agitated depression means that depression manifests itself as anger or angry outbursts. Again, those sorts of things can impact the learning environment, not just for that student, but for those around them as well. So catching them early, before the problem gets bigger or more disruptive, or completely interferes with their ability to function at school, is the ideal. That should be the goal. This may look familiar. Levels of screening matches up very well with RTI. We do screening in RTI as well. So these phrases, these terms should be familiar. Universal screening, which is all children will be screened will receive the screening. Selected screening, selected level, if there's children identified as being at elevated risk for developing issues, but it's not been diagnosed, that screening is that group can be that small group, so to speak, can be have selected screening. And indicated or targeted screening is that there's a diagnosis, but we're trying to determine how their disorder is impacting them in the academic environment. So behavior scales and things like that are targeted screenings, and that information can be very useful to a treatment provider or a treatment team in addressing those issues that are giving some insight into the things that are most problematic for that kid and can help them focus their treatment regimen. So for different school levels, there's different targets for screening. So in preschool, you're looking for the 3 to 5 age range. You're looking for developmental delays. You're looking for pervasive developmental disorders and emotional behavioral problems. So this is where you're ruling out things like you might be doing screening for things such as autism spectrum disorder issues, delays in learning or other developmental delays. You're looking for more pervasive developmental disorders. This is where these things are emerging to the point where they can be screened for. In elementary school, you're looking for emotional and behavioral problems. By this time, you'll have identified those that have significant developmental delays or PDD. And here in elementary school, more likely you're going to be looking for ADHD. You're going to be looking for, it might be screening for anxiety or those sorts of issues. And then in middle and high school, you're looking for, this is where more significant mood disorders or other sorts of behavioral disorders start to emerge. So depression, anxiety, suicidality, substance use. Those are the things that you're going to be screening for, because those are the things that are, again, most problematic at each level as far as students' ability to learn, is what you're going to be looking for. Pardon me. So types of screening. So broad, where it's broad screening is it's a shotgun approach. You're looking at a range of issues, and you're looking for factors that increase risk for disorders as opposed to specific disorders. So so this is something that's it's not a very sensitive tool, but this is a type of tool that will that's a good snapshot of the whole of the school culture, as far as if you're looking for data to where to point your resources. Broad screenings would be helpful. Specialized screenings are looking for high-risk symptoms. So these are symptoms that could point in the direction of multiple types of disorders, but isn't necessarily looking at a specific disorder or specific set of disorders. It's basically identifying symptoms that are indicating that child is at high risk for some form of behavioral health issue. And then targeted screenings are looking at very specific issues. It could be a screening for eating disorder, it could be for anxiety or OCD, it could be for substance use. So you're looking for something very specific with a targeted type of screening. So when you're looking at screening instruments, there's some good ones, and we'll talk about we'll only be looking at good ones today. Just pointing in the direction of what some good screening tools would be for your use in the school setting. It's a matter of choosing a tool. You want to make sure that it has high sensitivity, that it's actually targeting and picking up what it's supposed to be. Specificity, so you're also making sure that you're weeding out and identifying those that are not targeted by this particular screening. So it's the flip side of the sensitivity coin, and that there's good negative and good positive predictive value, meaning that positive predictive value is that when someone has a positive test result, that it's in line once they have a full evaluation that is correct, that it's pointing in the right direction. Negative predictive value is looking at how someone who's trying to gain the screening, so to speak, that it's sensitive enough that you can pick up that someone is being not entirely forthcoming on the screening. So we're going to talk about some specific instruments. This is an example of a broad instrument. This is the pediatric symptom checklist. There are links on these pages so you can take a look at it. Download it. A lot of these are free. Some screenings cost either per license, meaning that you got to pay to be able to administer that screening. In general, that a fee and then you're able to do it, or it's fee per administration, meaning that each time you do the test, there's a cost associated with it. Most of the tests that we're going to screening tools we're going to look at are free and relatively simple to administer. So the pediatric symptom checklist, this is something that's used fairly widely with pediatricians. So what it's screening is internalizing symptoms, which is more on the depression end of things, externalizing or externalizing symptoms or conduct behaviors, and attentional issues. There's a long and a short form. Long form is 35 items, short form is 17 items. It's indicated for youth ages 11 to 18. And if you look here as far as the stats, again, it has good sensitivity, is 0.95, and it has, you want to look for low specificity, which is meaning that it's being accurate in what it's trying to predict. So the parent can answer it. It's good for it's good for either the parent or the youth to answer these questions. It has good accuracy. Again, it's downloadable from the Massachusetts General website. Um, and if you just you can copy and paste that link, and it'll take you right to the page where that screening is. And it gives a good overview of it and scoring and all that good stuff. Strength and difficulties questionnaire. Here's another simple screening tool. It's a screen for emotional symptoms, conduct problems, hyperactivity, inattention, peer relationship problems, and prosocial behavior. 25 items, takes 5 to 10 minutes. Again, youth, if they're taking themselves, have to be between the ages of 11 and 16. The teacher or parent is filling out, you can use it down to age 3. So this is something that has, it's not as, again, going back to, it's not as sensitive, but it is specific. And that is, again, available at the website listed below.
I can tell you, Don, that I have used this particular instrument myself in some contexts with some young people who were in danger of getting involved with the juvenile justice system. And it was really helpful in terms of identifying what specific types of topics I should cover in the group I was doing with them. So it might be really useful for those who are implementing some social emotional learning pieces within their programs.
So this is something that used as a selective screening. So it's identified group, and there's a whole area of, say, for screening for kids that might be potentially involved with juvenile justice, how likely they are to react to a diversion program, for instance. So again, it's depending on the context you're using it for. That's a good point, Dale. You can utilize these screening tools to target what you're going to cover in a support group or a psychoeducational group or a support group of some sort.
Absolutely.
Let's see. So the Symptoms and Functioning Severity Scale by Peabody out of Vanderbilt. Screen for, this is more extensive, total symptom severity and functioning, again, internalizing symptoms, externalizing symptoms. Takes 5 to 7 minutes, and it's important to look at how long these scales not only take to administer, but you also want to take a look at how long they take to score, which will determine what scale you're going to use based on what your need is. If you're looking for something, if you're doing a universal screening, you don't want a screening tool that you have to hand score. If you're administering a test to 1,000 or 1,500 kids or 2,500 kids like I had to do, you want something that you can send somewhere that it can be compiled and scored, and the data can be compiled for you in a useful format. If you're doing smaller groups or single classrooms or things like that, a hand scored scale is not as daunting a task. So, and this scale can be done by a teacher, parent, or the youth, ages 11 to 18. Specialized. So we're looking at something more specific here. This particular one, the child behavior checklist, teacher checklist, youth self-report. These are often used in special education settings to really target interventions that are going to be implemented in the classroom or outside the classroom. It's pretty extensive. It's almost 120 items. So it's not something that you're going to be doing very frequently, but this is very, you're not going to be doing this as a universal screening. This is more to target interventions. So things that are assessed are aggressive behavior, anxiety, depression, attention problems, conduct issues or rule-breaking behavior, social problems, somatic or physical ailments or complaints, somatic complaints. Thought problems, meaning looking for things that might be indicative of a thought disorder that might be emerging. You'll see this more with older adolescents. And again, whether or not they're also looking at things like being withdrawn or depressed. So for a teacher and parent, it can be administered all the way down to age 1.5. Youth can self-report from 11 to 18. The website's at the bottom. The $ means this one costs money to administer. The other ones, as you notice, the websites do not have that $, meaning these are free. So just to, on a go-forward basis, don't add the $ to the website address. That just means that this costs money to administer. The BASC, Behavior Assessment System for Children. This is very widely used in behavioral health settings. So in a therapist's office, in a particular psychologist offices. So it's looking at different domains, including hyperactivity, aggression, conduct disorder, anxiety, depression, somatization, which refers to physical or medical complaints without a physical or medical basis. Atypicality, meaning that it's not a typical, having symptoms that are not a typical presentation for another issue. Social withdrawal and attention problems. It also looks at adaptive. There's a section of the BASC that can be used to look at adaptive domains. What are their strengths? Adaptability, social skills, leadership, activities, daily living, which is referring to things like showering and brushing your teeth and hygiene and getting up and attending to self-care issues, functional communication and adaptive skills. So this is one of the few screenings that you're actually looking at strengths, which can be helpful in small screening settings to be able to tailor interventions that they will have some success with, because it is addressing and reinforcing their strengths. It's a very extensive. This is depending on which modules you do, can be up to 160 items. Teacher or parent can do this for, and there's a preschool, an elementary, and an adolescent version of the BASC. So a teacher and parent can do ages 2 to 5, 6 to 11, 12 to 21, and youth can self-report on this screening from either the 8 to 11 or the 12 to 21 version. Pearson puts this out. Pearson specializes in creating and distributing, selling assessment and screening tools. So again, this is available online, but it does cost to administer. So other screenings that you can take a look at. Massachusetts General, which is a great resource in their psychiatry area, does a child adolescent psychiatry screen that's free. TeenScreen, which I think we'll talk about in a little bit, is a predictive scale, meaning that it's looking at things that and trying to determining if there are behaviors or symptoms that are predictive of emerging or developing issues. The voice diagnostic interview schedule for children is another one that costs as the systematic screening for behavior disorders. These sorts of screenings are specialized and more likely to be administered if it's already been determined that that it's likely this kid has some sort of issue, and it's more to verify what's already suspected and to get them connected with the appropriate treatment provider for their particular issue. Some targeted, the Swanson, Nolan, and Pelham checklist for ADHD, Vanderbilt ADHD scales, both of which are free. And and the Connors rating scales, which are not free. But we utilize the Swanson-Nolan pretty frequently. I mean, that's what we use at the facility that I work for. Anxiety. Anxiety is a very the significance and rise in anxiety can't be understated. So those that with anxiety that go unaddressed or untreated, are at risk for developing more significant anxiety disorders that could include school anxiety and school refusal. The kids refusing to come to school, you don't necessarily need to do a screening, but good universal screening around anxiety can be helpful in identifying those kids that would be at risk for school refusal. There's not much we can do with a kid unless we actually see them. So if they're not in school, we're not able to help them. So if I could put a plug in for any issue to be screened for at any grade level, anxiety would be at a high school level, substance use certainly, but anxiety is a pretty close, is far more detrimental to someone's academic success, pathological anxiety, meaning a diagnosable disorder, than at other grade levels, at pre-high school grade levels. So having a good sense of who might be dealing with it and intervening with those kids early can yield some real good long-term results. If there's anything good about anxiety, is that people do not like to feel anxious. They don't want to feel like that. So if you're able to identify it and get them some help, anxiety is very responsive to treatment. So there's a couple scales that are free to use: the Self-Report for Childhood Anxiety-Related Disorders out of Pitt, and the Leibowitz Social Anxiety Scale for Children and Adolescents out of University of Massachusetts. Again, both of these are free. The Beck Anxiety Inventory is somewhat of is probably the most wide. The Beck Depression Inventory and the Beck Anxiety Inventory are very, very widely used, but it costs money to administer. So it's a good idea, depending on what resources you have. The good thing about the Beck is easy. Beck inventory is easy to administer, and it's not long. So it's good for larger scale screenings, but there's a cost associated. Then there's a multidimensional anxiety scale for children and the state trait anxiety inventory for children. These are all of these are good, solid screenings for anxiety. It's just a matter of what your needs would be based on your resources and the amount of kids that you have to screen. So for depression, Center for Epidemiologic, God, that's a hard one, studies depression scale out of brightfutures.org. And the Columbia, we utilize the Columbia extensively, DISC depression scale. Again, Beck Depression Inventory is for youth. Children's Depression Inventory, the Columbia Health and Suicide Screen, and the Reynolds Adolescent Depression Scale. The Columbia is a little bit longer, but it's got the best research behind it as far as its sensitivity, and it's free. The Beck is certainly easier to administer, but there's a cost associated with it. Again, to reiterate, if you're going to be doing a screening for a particular issue and it's going to be in a large scale, you got to take a close look at what your options are and pick something that's going to match with your particular needs and your particular resources. For substance use, we have the Personal Experience Screening Questionnaire, which costs money, the Alcohol Use Disorders Identification Test, and the CRAFT. The CRAFT is pretty good. It's short, and you can so it's easy to administer to a large group. And of course, what's not on here is the Illinois Youth Survey, which provides that the Illinois Youth Survey is good for obtaining data about your school building and culture around particular things, especially substance use. But you can craft, Dale, is it 15 questions, I believe?
Yes, it is.
You have 15 questions that you can add. So if there's something else you want to screen for, to identify in your school building where you need to put your resources, you have 15 free questions, so to speak, free-form questions that you can craft yourself and add to that questionnaire. So if you want to look at things like eating disorders or self-injury or depression or anxiety, or gambling or risk-taking behaviors, you can craft questions to look at that to see if it's something to solidify and get some data on what your suspicions are as you're working with kids. You see something coming up over and over again. Again, it's good to get some data to back up the argument to your administration. You need more resources, or you need to dedicate resources to that particular issue in your building. So there's a whole the number of substance abuse screening tools that are out there are multitudinous, but these are three that we found are pretty reliable for screening substance abuse amongst adolescents.
And just to add to that, the Illinois Youth Survey piece, it is administered every 2 years, and it is free to any school in the state of Illinois. That information is compiled in a specific report to your school. Only you see your own data. The rest of that data then is compiled at a statewide and countywide level, depending on how many take it in a county. So you can compare and contrast against the state and local averages.
Right, and again, the thing to keep in mind is this is something that is something that's good for what's going on in your building. It would not be useful at all in identifying the needs of specific kids. That this particular kid has this particular need. But it's good again to make an argument that you need particular resources for a particular issue in your building. Eating disorders, the SCOFF. One other thing about substance abuse is, and that's not listed here because there's not a specific website, but you can Google it. There's a good short screening that's useful when you might have a kid in your office. It's called the CAGE, and the CAGE is an acronym. So it's a 4-question screening that if they answer yes to any of the 4, then some additional assessment or evaluation would be needed. So it's the C stands for concern. Has anyone voiced concern over your alcohol or drug use? A stands for amount. Has there ever been concern about how much you're drinking? So if you Google CAGE substance assessment, it'll give you the 4 questions. But it's a good, quick and dirty screening tool. It's not good for widespread screening, but it's good for one-on-one screening purposes. The reason I bring that up is the SCOFF is similar. The SCOFF is a 5-question one-on-one screening for eating disorders. So if they answer yes to any of the 5 questions, then certainly it would be appropriate to refer them for further evaluation. And then nonverbal learning disabilities, there's a children's nonverbal learning disability scale that is available as well online. ASD, autism spectrum disorders, there is a ton of screening tools for ASD, just a ton. Here's a list of those that we have found useful or accurate for the purpose of screening autism spectrum disorder. So the Autism Treatment Evaluation Checklist, the Childhood Autism Test, which is for infants. So if you have an early intervention program that you work with, that's something to look at. The Pervasive Developmental Disorder Screening Test. These three are free and available at the websites listed. The Autism Screening Instrument for Educational Planning, the Childhood Autism Rating Scale, and the Gilliam Autism Rating Scale all come with a fee, but can be useful, particularly the Autism Screening Instrument for Educational Planning. The other two are, again, Pearson Assessments, who specializes in distribution of assessment and screening tools, is where that is available. TeenScreen, Columbia University's TeenScreen program, may have been something that you've heard of. There's a website available. There is a cost associated with it. The primary focus is mainly for parents to go on to look to screen for suicide. Secondary focus are depression, anxiety, alcohol, and substance abuse. Problems that are not a focus of TeenScreen or won't be sensitive to are schizophrenia or psychosis, which you typically don't see until usually at the very earliest older adolescents. So in young adults, typically psychotic disorders don't emerge until the late teens, early 20s. It doesn't focus on ADHD, conduct, or oppositional problems, or ASD, autism spectrum disorders, or other pervasive developmental disorders. There's a lot of controversy around it because there's an anti-TeenScreen website, teenscreentruth.com, that states that there's a very high chance that your child will incorrectly be determined to have a mental illness. So the reason I bring this up is that you have to be a careful consumer when it comes to screening tools. You have to know what you're screening for. You have to be very specific in your intentionality when it comes to doing screenings. What are you looking for? Are you looking to confirm something that you suspect? Are you looking to identify when a student comes to your office looking to identify where they might, where and if and where they would need more specific intervention or assessment or diagnostic interview, and gather enough information to point them and connect them with the right resource for that. Are you looking to get a data set that you can apply for a grant or make an argument to your administration or district administration that you need further resources? So you have to be, you have to utilize tools that are less assailable or unassailable in their validity. Something like TeenScreen, which there's quite a bit of controversy around, is not something you necessarily want to be the backbone of an argument to your administration, data gather there to get further funding, because it's if there's any controversy around it or its validity, it's not going to make a good argument for your case. Some concerns over broad screening or broad brush or universal screening is some concerns that have come up over the years that we've been doing this. Over identification of mental disorders. Are we too quick to label a kid? And that's a very real concern, because once a kid gets labeled, it's hard to shake. And once a kid gets a label and they're aware of that label, its presentation has to be you have to carefully present that and contextualize it for a kid, because you don't want them to identify who they are with what they struggle with. Mandatory versus voluntary screening is, and there's some controversy around that as well. Is there should screening be voluntary? Can you mandate screenings? You have to take a real close look at your school district policy around that. And is there value, or is there does mandatory screening create a skew in the data? Parental consent and youth assent. How do you obtain parental consent? Some districts have chosen to administer screenings, and that consent is implied unless the parents specifically opt their child out for that particular screening. There's been a bit of controversy around that. There's controversy around the youth agreeing to participation in the screening. There's a concern about privacy. Where is this data kept? How individualized is it? And then concerns with treatment. Is there a pressure to medicate kids when you have a screening tool that seems to indicate that this kid might be dealing with attentional issues or ADHD? Is there then a downstream pressure to parents to go to a pediatrician or a family practitioner or a psychiatrist who is, when that information is brought to them, their first indication is to medicate? Is there pressure to do that? So there's quite a bit of controversy around broad screening and what the downstream implications are that you have to be aware of and ready to address should they come up, if you're choosing to do some form of universal broad screening.
And certainly we would recommend that if any of those issues pop up, that you would definitely consult with your district legal representative to talk about those issues and figure out the best way to resolve those in terms of legal issues that might arise.
Exactly. Definitely consult with it. Most school district attorneys are going to be conservative and liability averse. So if you're thinking of doing some sort of broader universal screening, definitely run it by your district administration and have them run it by their district, the attorneys that represent the district, especially if there's a contest or a concern brought up by parents about it. So appropriate screening, a positive screen, so a screen that says, yes, there's something going on here, is not the same as a positive diagnosis. Screening, and you touched upon this at the beginning, screening only starts a process. Broad screen or other identification, teacher identification, peer identification of an issue should result in a more specialized or targeted screening. That positive screening should result in the referral for a clinical evaluation. And if that evaluation confirms that there's a diagnosable condition, that should result in a referral for treatment. So it's a narrowing down, it's a winnowing down effect of, yes, there's something going on, we think something's going on, yes, it's going on, let's take a closer look. Well, yeah, it really does look like there's something going on, and getting that person connected with the appropriate clinical resource to confirm a diagnosis and initiate treatment. And from a validity standpoint, school-based screenings and referrals should always be voluntary, and should include informed parental consent and youth assent. They really need to know what they're being screened for, and they really do need to consent to it, because otherwise it's not just the legal risk, it skews the data, it skews the outcome of the screening when those things are not in And that's about it. Thank you for your time. This is my email address. If you have questions that have gone unanswered or have other concerns, please feel free to shoot me an email. I'll be happy to answer any questions you might have. But this has been a brief overview of screening tools in the school setting.
All right. Thank you very much, Don. Appreciate your information and hope it was useful to everyone who's viewing this webinar. Again, if you'd like to see other topics covered in one of our webinars, please email me at the email address shown. Also, you can follow us on Twitter again at Student Assistance Center, SA Center PF, or email me to join our Student Assistance Center group site. Thank you very much for your time today.